بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, we will inshallah start a new series of lectures concerning the imaging of the arterial diseases, and this series will be composed of 4 lectures, and these lectures will deal mainly with the diseases of the aorta as well as the pulmonary artery. Then the first 3 lectures will deal with imaging of the aorta and the main pathologies that can be seen in the clinical practice, while the 4th lecture will be concentrated on imaging of the pulmonary artery. Then in the first lecture we will demonstrate some of the congenital anomalies that can affect the aorta, and will provide also some of the anatomic landmarks. These lesions will include the patent ductus arteriosus, aortic hypoplasia, coarctation of the aorta, interruption of the aortic arch, the DRE syndrome, aortopulmonary window, Truncus Arteriosus, aortic stenosis, vascular rings, and finally the Marfan syndrome. Of course, we can scan the aorta using the ultrasound and Doppler facilities, as well as the echocardiography, and of course the CT angiography and MRI as well. Echocardiography has many advantages, actually, being non-invasive and using no ionizing radiation, no contrast material. It is helpful in assessment of the aortic insufficiency, in the accumulation of fluids in the pericardium causing cardiac tamponade, and also in assessment of the myocardial ischemia. The 2 main obstacles against the CT scan are the radiation, of course, and the use of contrast material. And it is recommended whenever we are evaluating some of the vascular lesions in the pediatric age group, it's preferred to use MRI and MRA because of the absence of ionizing radiation. Then in order to enhance the value of CT in assessment of vascular imaging, we actually do not need usually to scan the patient before injection of contrast material. Sometimes this is necessary, like in the coronary imaging, to assess for the calcium scoring. But the images that are of value are those obtained in the arterial phase. Sometimes we need the help of the venous phase to see, to assess the organ perfusion, and to assess the possibility of bleeding, especially in cases of trauma. According to the literature, we can obtain images for the aorta with a little amount of contrast material and using the 64 slice multi-detector system. The anatomy of the aorta is divided into 3 main parts, or let's say 4 parts: the aortic root, the ascending aorta, the arch of the aorta, the descending thoracic, and the descending abdominal aorta. And there are specific measurements for each of these segments, but we will simplify these numbers to be helpful in the interpretation of imaging. Then this is the region of the aortic root, which is composed of three parts: the aortic annulus, the region of the aortic valve, the sinuses of Valsalva, where the coronary arteries are originating, then the sinotubular junction, which is a constriction between the aortic root and the ascending aorta. Then above the sinotubular junction is the ascending aorta until you reach the origin of the innominate artery, then the start of the aortic arch. And the aortic arch will end at by the end of the origin of the left subclavian artery. This is known as the proximal arch, and this is known as the distal arch. After that, we got the descending thoracic aorta. Then, what about the aortic isthmus? You know that there is a small channel that connects the aorta to the pulmonary artery during the fetal life, which is known as the ductus arteriosus. The distance between the subclavian artery and the region of the ductus arteriosus is known as the aortic isthmus. And this aortic isthmus should not exceed 5 millimeter in length, because if it is more lengthy, then you may diagnose some of the lesions like hypoplasia of the aortic arch, as I will mention in a moment. Then these are the measurements that used in the clinical practice. The diameter of the aorta at the sinuses of Valsalva here, and then this white line should be less than 4 centimeter in males and less than 3.6 centimeter in females. The diameter of the aorta at the sinotubular junction should be less than 3.5 centimeter in males and 3.2 centimeter in females. And the diameter of the proximal ascending aorta, and this dotted white line, should be less than 3.8 centimeter in males and 3.5 centimeter in females. Then we start the evaluation by the patent ductus arteriosus. The ductus arteriosus, as I have mentioned, is a small canal that connects the aorta to the pulmonary artery during the fetal life. And this ductus will functionally closes by after in the range of 20 hours after birth. If the ductus remains patent for 3 months after birth, then you consider the diagnosis of patent ductus arteriosus, which represents about 1 in 2,000 full-term births and account for about 8% of congenital heart disease. It is more common in females than in males, and is seen with relatively high prevalence in premature babies. Patent ductus has been associated with maternal rubella, chromosomal abnormalities, single gene mutation, and X-linked mutations. Actually, the patent ductus is not a serious problem, so the patient can grow up with little complaints, and he can see it in the adult life. So in the adult life, the presence of patent ductus arteriosus will affect the left side of the heart. Meaning that the left ventricle will enlarge and also the left atrium will enlarge. And as similar to any left to right shunt, there should be increase in the pulmonary vascularity, which is known as plethora. Then in the chest X-ray, you got cardiomegaly with left-sided enlargement, and you get increased pulmonary vasculature, which is known as plethora, and you may see sometimes that the ascending aorta is prominent due to the increased blood flow. And this is the follow-up of the same case after closure of the ductus by transcatheter approach. The Krishenko classification of the patent ductus include 5 types, and this will depend on the length of the ductus and also the configuration, whether it is constricted from the pulmonary side or from the aortic and pulmonary sides, or it has these different appearances. But the value of Krishenko classification is to help the interventional radiologist to select the correct device which is suitable for closure of the ductus. Then, whenever you are writing a report about a case with patent ductus arteriosus, you should fulfill these findings. Number one, the length of the ductus. Number two, the diameter of the aortic and pulmonary insertion sites. Number three, the diameter and the location of the narrowest portion of the ductus. Number four, the morphologic type according to the Krishenko classification, the presence of calcium or aneurysm along the course of the ductus. And if you can mention the angle of the ductus to the ascending aorta, it will be good as well. Then during the evaluation, you will see that the left side of the heart is enlarged and there is some dilatation of the ascending aorta due to increased flow. And if there are complications like the pulmonary hypertension and Eisenmenger syndrome, you should mention. And this is an example where you see that there is a connection between the ascending aorta and the patent and the pulmonary artery. This is the patent ductus. And as mentioned here that the transesophageal echo failed to demonstrate this ductus because of the interposition of the left main bronchus between the esophagus and the side of the ductus. And this is a good oblique view for the patent ductus, showing the opacified channel connecting the aorta to the pulmonary artery. And here is another example of what we call ductus diverticulum, meaning that it looks like a diverticulum. It is patent from the aortic side, but is closed from the pulmonary side. And also you can see some calcific spots along the course of the ducts. The next lesion is the aortic hypoplasia. And this aortic hypoplasia usually affects the aortic isthmus. And it is mentioned in the literature that the distal part of the aortic arch and the isthmus is usually tapering in the first 3 months of life. But the persistence of this appearance is diagnostic of aortic hypoplasia. Then the aortic hypoplasia is diagnosed by abnormal small caliber of the aortic isthmus and distal part of the aortic arch, and the increase in the length more than 5 millimeter in infants, as I have mentioned, indicates that this is one of the stigmata of aortic hypoplasia. Sometimes aortic hypoplasia is associated with aortic coarctation, and you know that about 4 lesions occur in the region of the aortic isthmus: the patent ductus, the aortic hypoplasia, the coarctation of the aorta, as well as the aortopulmonary window, as I will mention in few moments. Then the hypoplasia may be associated with other cardiac anomalies like VSD, ASD, and patent ductus arteriosus. Sometimes it is mentioned that in echocardiography you should use this short axis view, which enables you to see the site of the connection between the aorta and the pulmonary artery, indicating the presence of a patent ductus arteriosus. This is a hypoplasia of the aortic arch, and you see the reduced caliber of the arch of the aorta, both in this MR angiographic image as well as in the DSA-aided cardiac catheterization. And this is CT angiography showing the marked decreased caliber of the distal part of the aortic arch compared to the ascending aorta, indicating that there is a hypoplasia of the aortic arch. Then we came to a famous lesion, which is the aortic coarctation, and this coarctation affects the region of the ligamentum arteriosum, which is the site of the patent ductus arteriosus. And aortic coarctation represents about 7% of congenital heart diseases. It is seen usually in males, and there is a stenotic segment in the region of the aortic isthmus, and it corresponds usually to the site of the patent ductus arteriosus. Then aortic coarctation occurs as a solitary lesion in about 80% of the cases, and in the remaining 20% it is usually associated with other types of congenital heart disease. Then association with coarctation include Turner syndrome, bicuspid aortic valve, intracranial aneurysms in about 10%, VSD and ASD, and Schwann complex, which is left ventricular outflow tract obstruction, and parachute-like mitral valve, then aortic hypoplasia, as I have mentioned before. The diagnosis of aortic coarctation is easy. It depends on the detection of a relatively narrowed segment or a focal area of narrowing, usually located distal to the origin of the subclavian artery. Then you may look for the presence of collaterals, which result from the impedance or resistance to the flow through the aortic arch, which develop through the internal mammary artery and intra-arteries, intercostal arteries, the thyrocervical and the thyroacromial trunks. Then you should look also for associations with the coarctation, like bicuspid aortic valve, left ventricular hypertrophy, and the presence of VSD. If the aortic coarctation is not treated, then it carries a risk of 75% mortality by the age of 45 years. And if you look to the chest X-ray, it may appear normal, and if the stenosis is severe, then you got some of the manifestations. One of these manifestations is what is known as the figure of 3 sign, which is the result of dilatation proximal and distal to the site of coarctation, leading to the formation of this three figure. Then also the presence of collateral circulation, especially of the intercostal arteries or the subcostal arteries. Then you got rib notching, and this rib notching is seen in all older patients because of the long-standing pressure of the collaterals on the adjacent bone, and it is usually detected from the 4th to the 8th rib. This is a diagram of the extensive collaterals that result from coarctation of the aorta. And this is a chest X-ray showing multiple subtle rib notching, and the MR angiographic image demonstrate very clearly the presence of extensive collaterals along the chest wall. The aortic coarctation may have some complications like congestive heart failure, and this is seen in about 25% of the cases, and they contribute to the most common cause of death in these cases. Aortic rupture and endocarditis intracranial hemorrhage. All are these can be associated with aortic coarctation. Coarctation can be detected by echocardiography, although they usually say that the region of the aortic arch is not that well evaluated by echocardiography. And this is the appearance of the coarctated segment. The main value of echocardiography is to detect the gradient across the coarctation segment, which is an important factor for the management. The disadvantages of echocardiography is the poor imaging window in some patients in this particular area, the long distance between the probe and the isthmic region, and it's difficult to evaluate, of course, the collateral circulation. Then we came to the interrupted aortic arch, which means that there is total interruption of the aortic arch between two segments, and of course there should be a patent ductus arteriosus. This interruption of the aortic arch is rare. It accounts for only 1% of congenital heart disease and is thought to be due to the exposure to teratogenic agents. There are two types: the simple one, where you see only VSD and the patent ductus arteriosus, and the complex one, which is associated with many other congenital anomalies like Truncus Arteriosus, transposition of the great vessels, double outlet right ventricle, aortopulmonary window, functional single ventricle, and DiGeorge syndrome. Then interruption of the aortic arch has a survival rate at 16 years in of about 65%. There is also a classification for the interruption of the aortic arch, where you got interruption distal to the origin of the subclavian artery. This is the type 1, which is commonly seen in the clinical practice, or type A. Type B, the interruption occurs between the left common carotid and the left subclavian artery. Type C, where the interruption occurs between the innominate and the left common carotid artery. Then if you look here and you see this area of complete interruption, which is different, of course, from the aortic coarctation, where there is still a patent lumen but is very narrow at the site of coarctation. And the chest X-ray may show similar findings like coarctation of the aorta, including rib notching and the enlargement of the left ventricle. Then you may use echocardiography to assess the site of interruption and to also to identify associated abnormalities. The value of MRI, of course, beside it is non-invasive and uses no ionizing radiation, its ability to see the length of the interruption and the origin of the great vessels and associated cardiac anomalies. This is an example of the type A aortic arch interruption after the origin of the left subclavian artery with extensive collateral circulation along the chest wall, and also you can identify the bicuspid aortic valve. Another example of type A interruption of the aortic arch, and you got the defect after the origin of the left subclavian artery, and also you can see multiple dilated collateral circulation. DiGeorge syndrome is an immunodeficiency disease caused by deletion of genetic material from the chromosome 22q11.2. That this chromosomal abnormality will affect the thymus and results in impaired production of T lymphocytes, which will result in exposure of the patient to many of infectious diseases. Then the incidence is about 1 per 5,000 births, and there are about 180 anomalies included under this syndrome, but of course not all the anomalies are present in the same patient. This DRE syndrome commonly occurs sporadically, and in 10% it is inherited. Then they thought that this genetic abnormality will affect the third and the fourth branchial arches, leading to a defect in the development of the thymus and the parathyroid glands, and this will affect the production of T lymphocytes, which will result in many infections. Then the stigmata or the criteria or the classic findings of DRE syndrome include many of the abnormalities like conotruncal cardiac anomalies, VSD, fallot tetralogy, vascular rings, interrupted aortic arch, palatal abnormalities like cleft palate and cleft lip, nasal regurgitation, and behavioral problems, immunodeficiency due to reduced T lymphocytes with recurrent infections, hypocalcemia with characteristic facial features. Then this syndrome will affect the CNS, will affect the head and the neck, the musculoskeletal system, and the cardiothoracic system. Some of the cardiothoracic abnormalities include VSD, tetralogy of Fallot, aortic arch abnormalities, vascular links, and absent thymus and lung infection. Many of the head and neck abnormalities will include external auditory canal stenosis, middle ear abnormalities, prominent nose, thin upper lip, and this is one of the features mentioned everywhere, that the upper lip is usually thin compared to the lower lip. Then we came to the aortopulmonary window, which is the connection between the root of the aorta and the pulmonary artery, considering that both the aortic valve and the pulmonary valves are present. And this represents about 1.1% of congenital heart disease. The communication has the similar hemodynamics like patent ductus and the truncus arteriosus, and the heart failure is a frequent manifestation of aortic pulmonary window. When to suspect aortic pulmonary window, if you see unexplained severe pulmonary arterial hypertension or unexplained dilatation of the left side of the heart. The Moray classification of the aortopulmonary window, or the connections between the aorta and the pulmonary artery, include this appearance and this one and this one, and the final type is total absence of the septum separating the pulmonary artery from the aorta. Then this communication occurs more anteriorly between the ascending aorta and the pulmonary trunk. But you should have the reformatted images to be sure that both the aortic valve and the pulmonary valve are present. The condition may be isolated or associated with other cardiac anomalies like the fallot tetralogy, pulmonary atresia, Truncus Arteriosus, ASD, patent ductus, interrupted aortic arch. Then the defect can be visualized by echocardiography and also cardiac catheterization with injection of contrast material, and it's helpful to also assess the pulmonary vascular resistance and the pulmonary artery pressure. And echocardiography may not demonstrate the communication about 35% of the cases, and that's why we may need the help of CT or MR angiography, and sometimes you need the selective catheter angiography to assess the site of communication between both. And in my opinion, the simple CT scan of the chest with contrast material, not a CT angiography, can help in demonstration of this communication, as the contrast enhanced CT can demonstrate the ascending aorta and the pulmonary artery very nice, and there is no need for angiographic images, in my opinion. Then we came to the Truncus Arteriosus, which means that there is a connection between the aorta and the pulmonary artery, and there is a single valve. In the previous lesion, aortopulmonary window, there are two valves, the valve of the pulmonary and the aorta, but here, this is a single trunk with a single valve. And this truncus arteriosus supplies the systemic, coronary, and pulmonary blood flow by the presence of VSD. This is the left ventricle and the right ventricle, and there is a communication between both through the VSD. The truncus arteriosus represents about 1% of cardiac anomalies. A right-sided aortic arch is seen in about 35% of the cases. There is a common truncal valve which is different from the aortopulmonary window, where there are two valves each for each vessel. The prognosis is poor in cases of untreatment, and about or more than 90% mortality before the age of 1 year. There is also a classification for this truncus arteriosus, and you see the difference. Either the two arteries are united at their root, or you can see absence of the pulmonary artery and the trunk of the pulmonary artery, and the right and the left pulmonary arteries are originating directly from the aorta, and this is another configuration and another configuration. Then the truncus arteriosus, in the chest X-ray, you see that the heart is enlarged and is simulated by egg on side configuration. There is narrow of the cardiac pedicle due to absence of the thymus, and you got some increase in the pulmonary vasculature. And here by CT scanning, you see this is the pulmonary artery and this is the arch of the aorta. Both are connected at the root and they have a common valve. Another example, which is demonstrating very well the connection between the aorta and the pulmonary artery with a single valve for both. Then if you look here, this patient had the type 1 truncus arteriosus, which means that there is communication between the root of the aorta and the pulmonary artery in a patient with DiGeorge syndrome. And this arrowhead indicates absence of the thymus, which is one of the major features in this syndrome, and you can easily appreciate the connection between the aorta and the pulmonary artery. And this is a normal appearance of a CT scan of the chest, showing the pulmonary trunk and the ascending aorta not communicating with each other, and you see the shadow of the thymic gland in the anterior mediastinum. Another appearance or another case of truncus arteriosus, and you got connection between the pulmonary artery and the aorta. And you remember that this is different from the aortopulmonary window, where there are an independent valve for the pulmonary and another one for the aorta. Then we came to the aortic stenosis, which is divided into three types: stenosis at the level of the valve, and stenosis below the site of the valve, and stenosis above the valve. Stenosis at the site of the valve is the most common, and it is usually associated by bicuspid aortic valve, which may be congenital or acquired. Then bicuspid aortic valve is the most common congenital cardiac anomaly, present in about 2% of the cases. This is the normal aortic valve, 3 cusps, and this is the bicuspid aortic valve. The subvalvular aortic stenosis is associated with abnormalities in the heart like hypoplastic left heart syndrome, idiopathic hypertrophic subaortic stenosis, hypertrophic cardiomyopathy, and subaortic fibrous membrane. Then the supravalvular is an uncommon compared to the valvular type and seen in about 30% of the cases associated with Williams syndrome, and this syndrome is composed of hypercalcemia, elfin phases, pulmonary stenosis, aortic hypoplasia, and stenosis of the renal, celiac, and superior mesenteric arteries. Also, it can be seen as an acquired lesion in rheumatic valvitis, and this sometimes or almost associated with mitral valve disease. Sometimes you got calcification of the aortic valve leading to stenosis. This is what is known as elfin phases, which is described in the form of broad and thin upper lip, prominent ears, broad forehead, periorbital buffness, and the flat nasal bridge. This is one of the criteria of Williams syndrome, and uh, which is associated, as I have mentioned, with the supravalvular aortic stenosis. Sometimes these patients are asymptomatic for many years, and the symptoms include this classic triad of angina, syncope, and shortness of breath, systolic ejection murmur, diminished aortic component of the second heart sound, and there may be death, sudden death in severe stenosis after exercise. Then in the imaging, the imaging findings in aortic stenosis, you got post-stenotic dilatation of the ascending aorta, left ventricular hypertrophy or enlargement. The left ventricle sometimes may be of normal size, but it has concentric hypertrophy. Calcification of the aortic valve can be seen in the plain film and also by CT scan. Calcification of the valve usually indicates a gradient across the valve of more than 5 millimeter mercury, as you can assess by the echocardiography. And this is an example of dense calcification in the region of the aortic valve. The supravalvular stenosis represents 3 types. Either you have this constriction or narrowing above the sinotubular junction, or you got a diaphragm or membrane, or you got the tubular type, which affects most of the ascending aorta. I have mentioned before the Williams syndrome, which is associated with this type of aortic stenosis. Also, you may got abnormalities in the mitral valve. Aortic valve abnormalities occur in 50% of patients, most commonly the bicuspid aortic valve. Subaortic stenosis is seen in about 15% of the cases. Then valvular stenosis 70%, supravalvular stenosis 30%, and subaortic stenosis 10%, 15%. Then this is a supravalvular stenosis, where you got narrowing above the sinotubular junction of the aorta, which is demonstrated in this 3D images and also in the reformatted images. Another example of supravalvular aortic stenosis above the level of the coronary arteries, and you see the calcification in the sinotubular in the aortic, in the region of the sinuses of valsalva, and also in the ascending aorta. Now we came to the vascular rings, and by vascular rings we mean that the trachea and the esophagus are surrounded by vessels. The vascular rings are uncommon, seen in less than 1% of all congenital cardiac defects. Double aortic arch counts for 55% of the vascular rings, and we have three types of double aortic arch. Either the posterior arch is dominant than the anterior arch, and this is the most common, 75%. The anterior arch is dominant, and this is 20%. Both arches are of the same size, and this is only 5%. Due to compression of the trachea, there may be wheezes and stridor as common symptoms in children. Dysphagia may also be present in children and adults due to compression of the esophagus. The four artery sign means that there are two posterior subclavian and two anterior carotid arteries eventually arising from both arches of the aorta. Then we have about 6 appearances for these vascular rings, and this is the first one, which is innominate artery compression syndrome. Of course, this is not a vascular ring. It is just the pulmonary, the innominate artery is located more to the left side, compressing the adjacent trachea. Then you have aberrant right subclavian artery, which is originating from the arch after the origin of the left subclavian artery, crossing behind the trachea to reach the right upper limb. And here is the right arch mirror image, where you got, instead of left-sided aortic arch with the normal originating vessels, you got right-sided aortic arch with normal originating vessels, which is known as a mirror image aortic arch. Right-sided aortic arch with apparent left subclavian artery originating from the distal part of the arch, crossing behind the trachea to reach the left upper limb. Then double aortic arch with three major types, considering the size of the posterior and the anterior arches. The final one is the double aortic arch with atretic segment, meaning that this segment is not well developed, but you got the vessels originating from patent lumen. This is what we call right-sided aortic arch or mirror image aortic arch, where the aortic arch is to the right side and giving its usual branches. This is the left subclavian, left common carotid, the innominate artery giving the left subclavian and common carotid, or both originating directly from the aortic arch. And this is an example of double aortic arch. In the chest X-ray, you get broadening of the mediastinum only, but in the CT scan and the reformatted images, and you can see that there are two arches of the aorta, and you got these vessels on the left side, like the similar vessels on the right side. Finally, we came to the Marfan syndrome, which is a multi-system connective tissue disorder. It is an autosomal dominant, transmitted in about 70% of cases. It affects both sexes equally, and it has many manifestations throughout the body, including skeletal, cardiovascular, ocular, and other abnormalities. The prevalence is about 1 per 5,000 cases, and this is related to the dysfunction of the microfibrils, causing some disintegration of the connective tissue. This dysfunction may result in aneurysms, may result in vascular dissections, and it has so many criteria. Some are considered major and some are considered minor. And according to the literature, if you got two major criteria and one minor criteria, then you diagnose Marfan syndrome. But if you have only one major criteria, you need four minor criteria to support your diagnosis of Marfan syndrome. And this is a big list of the major and minor criteria of Marfan syndrome throughout the body, in the skeleton, in the eye, in the cardiovascular, in the pulmonary, in the skin, and also in the family. Then you may, of course, remember some of the major criteria and some of the minor criteria, not all this, but I included this in the presentation so that if you want to revise the major and minor criteria, it is easy for you. Then these are some of the criteria. Number one is known as dolichosteinomelia. And by this we mean that the span between the upper limbs is longer than the length or the height of the body. And if you divide this by this, and you got more than 1, and 1.05. Number two in the criteria is the hypermobility, as you can see here. Number three is known as the Walker-Murdoch wrist test. If you hold the wrist of one upper limb by the hand of the other upper limb, and you got overlap of the fingers, this is not usual in normal subjects. The fourth sign is known as Steinberg thumb sign. And if the patient is abducted the thumb and flexed his fingers, then the last or the distal phalanx of the thumb will surpass the palmar area. And as you can see here, if you try to hold your hand like this image, the thumb will not project beyond the little finger. Never in normal conditions, but in Marfan syndrome, you can see this distal phalanx is pointed beyond the little finger. Other stigmata of Marfan syndrome, they are numerous. Aortic aneurysm, dissection, bicuspid aortic valve, pulmonary artery dilatation, dural ectasia, scoliosis, spondylolisthesis, pectus deformities, protrusio acetabula, dolichosteinomelia, flat feet, hypermobility, ectopia lengths, when means that the lenses are not at their normal location, but they are ectopic in the posterior chamber. Then aortic lesions are famous in the Marfan syndrome, and they are seen in most of the cases, in about 90% of the cases, and these are the main cause of mortality. One of the important criterion is the annulo-aortic ectasia. Ectasia in the region of the aortic annulus, in this aortic root, and you got significant dilatation of this area, which is seen in about 70% of the cases. There are uniform dilatation of the sinuses of Valsalva, and this will extend into the ascending aorta with obliteration of the normal sinotubular ridge or the constriction between the sinuses and the ascending aorta. And then aortic aneurysms in Marfan occur in younger patients and enlarge more rapidly than in in the aortic aneurysms related to arteriosclerosis. Also, calcifications are not common in aneurysms occurring in Marfan syndrome compared to arteriosclerotic lesions. The average of death in untreated patients with Marfan syndrome and aortic aneurysm is about 35 years. So the literature recommend what is known as elective replacement of the aortic root. In patients with Marfan syndrome, this may be done before the enlargement or aneurysmal dilatation of the aortic root or the dissection. And this is a patient with Marfan syndrome showing huge dilatation of the root of the aorta and the dissection of the aortic of the descending thoracic aorta. You see the false lumen and the true lumen. Aortic dissection will be explained in full details, I think, in the second lecture or the coming lecture. Then this is big dilatation of the aortic root involving the sinuses of Valsalva. And this patient with Marfan syndrome showing the intimal flap denoting aortic dissection affecting the aortic root extending into the arch as well as in the descending aorta. These metallic artifacts are due to the repair of scoliosis, which is one of the major criteria of Marfan syndrome, associated usually with dural ectasia, as I will mention. Then this patient had exertional palpitation and dyspnea with skeletal features suggestive of Marfan syndrome, including the increased arm span, wrist and the thumb signs, kyphoscoliosis, and pectus craniatum. Then you got a big aneurysmal dilatation with no evidence of dissection and is classically involving the aortic root. And this is different from the arteriosclerotic aneurysm of the ascending aorta, which do not usually affect the aortic root. Then these are the prophylactic surgery is recommended when this prophylactic surgery means that you electively remove the aortic root before aneurysmal dilatation or dissection. This elective surgery is recommended when the diameter of the ascending aorta at the sinuses of Valsalva is 5 centimeters. There is rapid dilatation, 2 millimeter or 5% of the dilated lumen per year. There is a family history of aortic dissection. There is severe aortic valve regurgitation. The associated symptoms or progressive ventricular dilatation or dysfunction. This operation is known as Pin-Toll operation. I will show the diagram showing the operation itself. Then echocardiography is recommended to assess the changes in the aorta, to establish the aortic dimensions, to see the ventricular function and the function of the valve, to see if there is abnormal aortic compliance. And the echocardiography should be repeated 6 months to establish the rate of a change in the aortic diameter. Then more frequent imaging is indicated if the initial aortic diameter is more than 4.5 millimeter. And you remember these are the normal values mentioned before. And this is the difference between the aneurysm of the ascending aorta in Marfan syndrome and the aneurysm in the arteriosclerotic case. In Marfan syndrome, the aneurysm will affect the aortic annulus, including the sinuses of Valsalva and the sinotubular junction. But here, the aortic valve region is spared, the sinuses are spared, and the sinotubular junction is not involved, and the aneurysm is above this area. This is the Pin-Toll procedure, where you remove the dilated aortic arch and you spare the origins of the coronary arteries and you replace by graft, and you fix after that the origin of the coronary arteries. Bicuspid aortic valve is one of the criteria of Marfan syndrome, and it is seen in about 5% of the cases, while in general population it is seen in about 2% of the cases. And this bicuspid aortic valve is seen by echocardiography, and also you may have the contrast enhanced CT, as you can see here with nice demonstration of the site of the valve. About 65% of patients with Marfan had mitral valve prolapse, and also you got some dilatation of the pulmonary artery. Dural ectasia is considered one of the major criteria of Marfan syndrome, where you got expansion of the cecal sac with a scalloping of the sacrum and the also the lower lumbar spine. Acetabulum protrusion or protrusio acetabuli is also one of the features of Marfan syndrome, where you got medial protrusion of the femoral head pushing the medial wall of the acetabulum inside the pelvic cavity. And usually, if you draw a line, when this yellow line is known as the ilioischial line, the rim of the acetabulum in blue and the contour of the femoral head in green should be lateral to this line. In cases of protrusia acetabulae, the acetabular margin as well as the femoral head may touch or extend more medial beyond the ilioischial line. Also, because of this, you got more coverage of the femoral head by the acetabulum, similar to the Benser type of femoroacetabular impingement. In the hand, you remember the this test with the Walker-Murdoch wrist test and the Steinberg thumb sign. This is the Steinberg thumb sign, and this is the Walker-Murdoch wrist test. Also in the hand, you got what's known as the arachnoidactyly, and this is a very common characteristic of Marfan, where you measure the length of the metacarpal bones from the second to the fifth, and you measure the narrowest diameter of each metacarpal and divide this, and you got an index which is known as the metacarpal index, and if this index is greater than 8.4, it is considered abnormal. Scoliosis is also a major criteria of Marfan syndrome, provided that the angle of scoliosis is about 20 degrees or more. Then scoliosis is present in about 60% of patients with Marfan syndrome and is considered the major criterion, as I mentioned. And the CT, I think that the plain X-ray is quite enough for diagnosis of scoliosis and to see the progressive deformity and also to assess the angle of scoliosis, considering the bending to the left position and also to the right position. Dural ectasia is also a major diagnostic criterion of Marfan syndrome, seen in about 60% of the cases. You got marked dilatation of the cecal sac with scalloping of the vertebral bodies. Then the major criteria here composed of the width of the dural sac below S1 is greater than that above L4. This is S1, you measure the width of the dural sac, and you go to L4 and you measure the dural sac, then the dural sac here should be more than this, and this is considered one of the major criteria. Also, if you got an anterior meningocele, this is a major criteria. Minor criteria is scalloping greater than 3.5 millimeter at S1. In order to measure the depth of the scalloping, you put a horizontal line between the edges of the vertebra and a perpendicular line to the bottom of the scalloping. Then you measure this distance. Nerve root sleeve diameter greater than 6.5 millimeter is also considered a minor criteria. Then these are the grading of dural ectasia grade 1 with minor scalloping, grade 2 with more advanced scalloping, and grade 3 with the development of anterior sacral meningocele. Then pectus excavatum means that the sternum is the breast, and this is one of the criteria of Marfan syndrome. You measure the widest diameter of the chest and the narrowest diameter of the anteroposterior diameter of the chest, and you divide both, and you got the what's known as the Haller index. And the Haller index above 3.25 is considered positive for the diagnosis of Marfan syndrome. هذا وبالله التوفيق والحمد لله رب العالمين.